Hey Debbie, I'm going to be talking about shock right now. And right now I am in Mosby's and I am on page 115, Nursing Care of Clients in Shock. You're going to take a history of causative and risk factors. You're going to look at fluid intake and output over the previous 24 hours, signs of covert bleeding, rapid, thready pulse, hypotension, increased respirations, cold and clammy skin. You're going to look at their mental status and see if it changes. If they get restless or confused, progressing to lethargy and decreased LOC, chances are they're in shock. Cardiovascular status, you're going to look at ECG, hemodynamic monitoring, peripheral vascular assessment. And you're also going to look at their respiratory status, breath sounds, arterial blood gases, and O2 sat. So here's your planning and implementation. You're going to keep them warm. So we were talking about no cooling blankets earlier. That's right. You want to keep them warm. And you want to place them in the supine position. Monitor the hemodynamic status and vital signs. Monitor urine output and specific gravity. Urine output, urine output. That seems to be the case for all of these. You're going to take allay anxiety. You're going to administer IV fluids and titrate parenteral vasoactive medications as prescribed. Monitor O2 sat and provide oxygen therapy as indicated. So for most of shock, you're going to administer fluids and oxygen. For anaphylactic shock, remember we talked about that. That's the allergic reaction. The first thing that you're going to do is stop whatever is causing it. So if they're on IV, you want to stop the meds that you think might be causing it. You want to administer epi and oxygen. And I don't remember what else, but that was most of it. So that's shock. Let's see. And then on page 264 in Mosby's, we have question 56. A client is in cardiogenic shock. What explanation of cardiogenic shock should the nurse include when responding to a family member's question about the condition? It is a failure of the circulatory pump. So that's it for the questions about shock in that book. Okay, so my little Saunders critical care book. You are caring for a patient who had a GI bleed. They were given blood, blah, blah, blah. They started itching and couldn't get their wedding ring off, so they're swelling. Your first priority should be to stop the infusion immediately. So that's always going to be the case. Okay. 4. How is cardiogenic shock different from hypovolemic shock? An increase of fluid exists in the heart during cardiogenic shock, but not during hypovolemic shock. 5. What is the underlying pathophysiology of all forms of shock? Inadequate tissue perfusion. Hypovolemic shock causes a decrease in CO and pulmonary capillary wedge pressure. 7. A patient arrives at the ED with the chief complaint of temp 102, nausea and vomiting for 3 days. The patient is experiencing tachycardia with a sustained heart rate of 120 beats per minute, BP of 95/60, tachypneic at 26 breaths per minute. The nurse starts an IV knowing that the patient has deficient volume and is going to need a bolus of IV fluids. The initial treatment is with ding, 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 lactated ringers. Okay, what would be an appropriate intervention for a patient in septic shock who has the following? pH 7.29, PCO2 69, PO2 60, HCO3 32, SaO2 83, respiratory rate 36 breaths per minute, obvious labor, diaphoretic, and complains of being tired. This person is progressing into respiratory failure, so you want to provide intubation and mechanical ventilation. Number 9. Which patient is at greatest risk for septic shock? This one was the 86-year-old insulin-dependent diabetic woman with stage 4 sacral decube ulcer who was incontinent with an indwelling Foley. Remember, she was our walking infection. 10. Positive inotropic agents are given during septic shock to increase the contractility of the heart. Okay, moving on to Lippincott. Let's see. Page 393. Question 104. Which of the following is the most important goal of nursing care for a client who is in shock? You want to manage inadequate tissue perfusion. 105. Which of the following indicates hypovolemic shock in a client who has had a 15% blood loss? Systolic BP less than 90 millimeters of mercury. 106. Which of the following findings is the best indication that fluid replacement for the client in hypovolemic shock is adequate? Urine output greater than 30 mLs per hour. Urine output, urine output, urine output. Okay. Which of the following is at risk, is a risk factor for hypovolemic shock? Hemorrhage. Hemorrhage always leads to, not always, that's a horrible thing to say, but hypovolemic shock is normally hemorrhage. Okay. 108. Which is a priority assessment for the client in shock who is receiving an IV infusion of packed red blood cells in normal saline solution? Anaphylactic reaction. 109. The client who does not respond adequately to fluid replacement has a prescription for an IV infusion of dopamine hydrochloride at 5 micrograms per kilogram per minute. To determine that the drug is having the desired effect, the nurse should assess the client for increased cardiac output. 110. A client is receiving a dopamine hydrochloride for treatment of shock. The nurse should monitor blood pressure continuously. 111. A client who has been taking warfarin has been admitted with acute rectal bleeding in the following lab results: INR 8, hemoglobin 11, hematocrit 33%. In which order should the nurse implement the following physician prescriptions? You know this is going to be on there. The first thing you do is administer IV dextrose 5% in half normal saline. The second thing you do is give 1 unit fresh frozen plasma. The third thing you do, administer vitamin K, 2.5 milligrams by mouth. And then the last thing you do is schedule for the sigmoidoscopy. So again, administer IV dextrose first, then give the fresh frozen plasma. Third, administer vitamin K, and then fourth, schedule for the sigmoidoscopy. Okay, 112. When assessing a client for early septic shock, the nurse should assess the client for which of the following? Warm flesh skin. 113. A client with toxic shock has been receiving Rocephin 1 gram every 12 hours. In addition to culture and sensitivity studies, which other laboratory findings should the nurse monitor for? Serum creatinine. Creatinine, creatinine, creatinine. Okay. 114. Which nursing intervention is most important in preventing septic shock? Maintaining a sepsis of indwelling urinary catheters. 115. Which of the following is an indication of a complication of septic shock? Acute respiratory distress syndrome. So that is it for the Lippincott. But I think that we should talk about shock a little bit more. Again, the signs of shock are going to be increased heart rate, low blood pressure, tachypnea. So always remember that. The different kinds of shock. Hypovolemic shock, the most common form of shock, is caused from an inadequate circulating blood volume in the intravascular bed. As with all forms of shock, circulating oxygenated blood flow to the body organ decreases. Lack of oxygenated blood leads to inadequate tissue perfusion, causing cellular hypoxia, organ failure, and death. So that's going to be the one where you really, really, really want to do fluids. So, make sure you know that. It says treatment of the patients in hypovolemic shock is focused on identifying and treating the underlying cause. So, like if they're bleeding internally, you want to go take them to surgery and fix that, whatever. It involves maintaining oxygenation and perfusion by keeping the mean arterial pressure equal to or greater than 60 millimeters of mercury. They are treated according to their BP, urine output, hemodynamic parameters, lab results, and clinical status. They may require massive fluid resuscitation and diligent monitoring of the patient's intake and output to stay ahead of the patient's fluid needs. So these questions could have some blood questions too, like blood admin questions. So just remember that. Okay, septic shock. What is septic shock? It is an inflammatory response. The septic process is initiated by the launch of immune mediators that are part of the inflammatory reaction. This process starts a chain of complex interactions that are controlled by numerous feedback mechanisms. Eventually, the immune system is overwhelmed, and the process actually harms the body. Systemic inflammatory response syndrome, SIRS, refers to a host's response to a variety of clinical insults, both infectious and non-infectious, and is part of the acute sepsis process. So remember that. So what we need to know about that is it's basically an infection. What we do is maintain a patent airway and use oral or nasal airway if needed. In the event of respiratory failure, the nurse should be prepared to assist with intubation, which is usually performed by an attending physician. Initial intervention is oxygen delivery at 5 to 6 liters per minute via nasal cannula. To assess the adequacy of oxygenation, you need to look at your pulse ox, ABGs, and there could be a need for mechanical ventilation. You want to monitor their vital signs frequently. You want to look at their map closely. And if it's less than 60, again, that negatively affects perfusion of the brain and kidneys and should be immediately addressed. What else? It says another aim of treatment of septic shock is to maintain blood glucose levels of 150 milligrams per deciliter. Maintaining renal perfusion is a priority and is monitored by urine output. And a urine output of greater than 30 mLs per hour is adequate renal perfusion. And it says catheter care is essential because the catheter can be direct entry port for microorganisms. So that's a pretty big deal. And then you want to isolate the infective organism through blood, urine, sputum, or other cultures, and treat with antibiotics. It's really important to treat the underlying cause of the shock. So, let's talk about, I think, cardiogenic shock, if I can find it. Okay. Cardiogenic shock is a special kind of shock during which the heart does not adequately pump enough blood to the body's tissue. When the heart does not contract adequately, blood flow to the tissues decreases and oxygen delivery fails. So when it falls below critical levels, tissues fail to function and eventually break down. Blah, blah, blah. Okay. So, you see a low systolic BP of less than 90 millimeters of mercury. They're tachy. The pulse becomes weak and thready. Okay, so as the heart becomes more hypoxic, ischemic changes may be observed on the ECG. Anyway, so to prevent cardiogenic shock, all treatments must be aimed at restoring blood flow and oxygenation and administered early and quickly to limit organ damage. You have to do emergent cardiac revascularization through thrombolytic therapy, angioplasty, or bypass surgery to prevent mortality and prevent more myocardial ischemia. So, for patients who have to go through thrombolytic therapy, you're going to always assess for bleeding. That's a really big deal. So, and you are going to review the patient history, determine patient age, onset of symptoms, medications, allergies, presence of hypertension, and recent history of surgery, trauma, bleeding, or stroke. History of bleeding. So, they might require total circulatory support for mechanical devices such as an intra-aortic balloon pump and a left ventricular assist device and extracorporeal life support or pharmacological interventions. So, that's pretty bad stuff. You don't want that to happen. Pharmacological intervention for cardiogenic shock. I think if she's going to ask us anything about cardiogenic shock, it's going to be pharmacological intervention. So, here we go. The cause of cardiogenic shock may be left heart failure, which is the most common, right heart failure, or cardiac tamponade. A number of available pharmacological agents or treatments are available, and the best combination is determined by the cause of the pump's failure and the patient's response. So the more common agents are dopamine. It increases renal perfusion at lower doses. Oh, she was talking about this, like the lower doses, the mid doses, the high doses. Anyway, it increases renal perfusion at low doses and causes an increase in CO, heart rate, and systemic arterial pressure at higher doses, which increases the pumping action of the heart. So that's a positive inotropic agent. So for cardiogenic shock, you're probably going to deliver a moderate or a high dose. Dobutamine increases the pumping action of the heart and decreases ventricular filling pressure. Norepinephrine, which is also what she was talking about, the Levophed, which we had no idea what the hell she was saying in class. It's norepinephrine, Levophed, a profound peripheral vasoconstrictor that is used in patients with extremely low systolic pressure, below 70 millimeters of mercury, to prevent total circulatory collapse. This one's big. So, dopamine and norepinephrine, huge. Sodium nitroprusside decreases arterial resistance and is often used to decrease SVR, afterload, and systolic BP. And then, of course, nitroglycerin. It's a vasodilator, so that's going to help. And then diuretics can decrease body water, pulmonary edema, and systemic fluid overload. You have to be kind of careful with that. Just because, yeah. Anyway. And then, of course, oxygen therapy is really important for all of the shock patients. So, anyway, I think I've pretty much beat shock to death. So, hopefully that helps.